Welcome, everyone, to the April 12th, 2023 regular meeting of the Washington Township District Board of Directors. I invite you all now to join with me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maui Avenue, Fremont, and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, could you take the roll for me?
Yes. Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace. Director Yee.
Present.
Director Epen.
Present.
Thank you.
You're welcome.
Next item on our agenda is our oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public at this time who would like to speak? Hearing none. Cheryl, are there any written communications?
There are none.
There are none. We'll now move then to our consent calendar. Consent calendar consists of items that are voted on as a block. May I have a motion on that, please?
Are you ready for that? Mr. President, I move that the Board of Directors approve the consent calendar items A and B. Second.
We have a motion and a second. Cheryl, would you take the roll on that?
Yes. Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace. Director Yee.
Aye.
Director Epen.
Aye.
Thank you very much. The next item on the agenda is a presentation. Kimberly, if you could introduce that for us.
Yes, it's my pleasure to introduce Laura Anning. She's our Chief of Patient Experience. Laura Anning is our new Chief of Patient Experience. She joined the Washington team 3 months ago from Chandler, Arizona. She obtained her sports medicine exercise physiology degree at Eastern Michigan University and has been a leader in healthcare and wellness for over 30 years. She comes to Washington after 10 years at Banner Health with leadership roles in patient experience, physician experience and development, and most recently in nursing experience and development. Laura is a former talent development director, account executive, and is currently pursuing her executive coaching certification. So welcome, Laura. I think you're on mute.
Of course I am. Thank you, Kimberly. I appreciate the introduction. It's so nice to meet all of you. I'm going to go ahead and share my screen. All right. Can you see it?
Yeah.
Yes.
Awesome. All right. Well, anyway, it's like I said, it's nice to meet you, and I really appreciate the opportunity to talk about my favorite topic, which is patient experience. And I noticed when I recently informed people that I was going to be moving from Arizona to California to pursue my dream job, a lot of people asked me, so Laura, what is it that you do exactly? And then when I told them I work in patient experience, they then said, well, what is patient experience? So for the next 15 to 20 minutes, I'm going to share a variety of patient experience information. And I want to begin with a story. And this happens to be my own personal story. So on November 11th, 2021, I was on a family vacation in Maui, and my sister asked me if I wanted to go horseback riding with her. And this is a picture of my horse selected for me, and her name was Grace. And the scenery was beautiful. I absolutely loved it when we were walking near the ocean. And towards the end of the ride, the guide asked all of us if anybody was interested in experiencing their horse run. And I thought that trotting was real fun. So of course I raised my hand and I'm like, yeah, that sounds great. And so after some instruction, the guide whistled, and Grace went from a standing perfectly still to a full out sprint. I immediately heard a loud crack coming from my back and felt tremendous pain. I literally saw an image before my eyes of me in a wheelchair. I was absolutely petrified. And until that accident, I was really active with hiking and hot yoga. And I thought I wouldn't be doing this any longer. And fortunately, the stables were nearby. So although I was kind of slumped over the horse, I was able to make it back and get off the horse. However, I wasn't really able to walk and let alone get in the car. So the ambulance arrived, and that was the beginning of my patient experience. So the ambulance took me to the Maui Memorial Medical Center's emergency department, and the first person I interacted with asked me for my ID. I literally was sitting in the fetal position in the wheelchair outside, and I don't remember much about that encounter. I was triaged quickly and taken to a room where I met 4 amazing nurses. They demonstrated so much empathy when they told me they were going to need to straighten me out. And I thought that I was already in a lot of pain, but straightening me out was excruciating. And I pretty much have a high pain tolerance. So then I met my ED physician, who asked me a lot of questions. He listened, he explained to me what was going to happen next and why. He also demonstrated empathy, and he assured me that I was in good hands. After this interaction, I had my first CT scan and MRI. Never had that before. And I remember the techs made a connection with me immediately and also demonstrated a lot of empathy. I thought, wow, everybody here is so nice. They asked if I was warm enough, gave me a blanket, and they asked me what music I wanted to listen to. After receiving the test results, the night shift nurse informed me that I wouldn't be leaving tonight because I indeed fractured my L1. There wasn't a bed ready, so I stayed in the ED for a few hours, and my nurse checked on me frequently. He monitored my pain. And then at about 3 a.m., a transporter arrived to take me to my room. He said, wow, you're really lucky, Laura, because you have a private room facing the ocean. He also made a connection with me, asking how I hurt myself so badly with actually falling off the horse. And as I was being transported, I remember looking at the ceiling and thinking, oh, wow, they need to change some of those ceiling tiles. I have to tell you that working in patient experience has trained me to observe pretty much everything, and I have really high expectations. After arriving to room 302, I was greeted by my nurse and my CNA. They introduced themselves and explained how to call them, how to operate the bed, and even brought me a ham sandwich and a Diet Coke. As I was looking around, I noticed my room was clean, it was dark, it was quiet. I even had a view of the ocean and the mountain that I was planning on riding a bike down the next morning. The following days, I interacted with occupational therapy, physical therapy, environmental services, tray passers, and everyone who walked in the room attempted to connect with me. They introduced themselves, they explained to me why they were there. And when I said thank you, they responded with my pleasure or you're welcome and no problem. I made a special connection with my physical therapist, Sean. I remember he said, Laura, this is an accident. It's not going to change your life, or it better not. I needed to hear that at that moment. After 4 nights, I was discharged with medications in my hand and information to share with my primary care physician and probably a specialist in Arizona. This was my patient experience at Maui Memorial Medical Center, with the exception of my experience with the billing department a month later. That's a whole nother story. So what is patient experience? A patient experience begins the moment a patient chooses or referred to our system. The experience describes their journey and range of interaction from scheduling an appointment to seeing a specialist to an inpatient stay, filling prescriptions, follow-up appointments, etc. And our goal is to monitor and to analyze and improve every step of that patient's journey. So what is it I do as a chief of patient experience? So at a high level, my role will be focusing on these 4 areas on the slide. In the past 3 months, I've spent a lot of time currently trying to understand the current state and what ideal state would look like. I've also been trying to learn a lot about the patient population, and I've met so many incredible leaders and employees here. I can tell you this is a very special culture, and it's not like anything I've encountered at any other health facility or system, and I've been to a lot. And I've accomplished this with a lot of rounding and shadowing, simply observing, and I go to a lot of meetings where I ask a ton of questions. And next, the focus will be on building behaviors and selecting high-value tactics and key drivers. I will also plan on focusing a lot on communication and sharing results and validating consistency of behaviors. And finally, there's also going to need to be we're also going to need to address obstacles and anticipate challenges and certainly ensure sustainability. So I want to change gears here and walk through how information is gathered about a patient, and I would say families as well, because that's their experience too. And after a patient has had an interaction, a paper or e-survey is sent randomly to selected patients. And the feedback is gathered by Press Ganey, and they provide us with our scores and comments. And the general categories for the questions are listed on this slide. And the overall rating that you see at the bottom, this is the question that most healthcare organizations select for their organizational priorities. And this is why. There is a question on all of the surveys that asks, how likely are you to recommend WHHS to your friends or to your family or your friends and family? And top box methodology, that's what they used, is used for scoring. And so what that means is that only the top answer, definitely yes, must be selected for it to count. So they have 4 choices, and the top choice is definitely yes. And that's what we want, because otherwise it doesn't count. And research shows that asking our patients to rate us based on likelihood to recommend to friends and family is the best indicator of patient loyalty. And this slide shows the formula to build trust and loyalty with our patients. You first take values, which is the patient first ethic, plus something that they call key drivers. And key drivers are what patients tell us is most important for them. If done well, they will likely lead to a definitely yes to recommend. And the key drivers, they vary by service line, and they even vary by unit, which really makes sense. For example, if there's a difference of what a mother would want having a baby versus somebody who is, getting a hip replacement. So based on over 1.5 million responses, our key drivers for the whole entire system, number 1 is staff work together to care for you. The second one is staff is included in their patient's treatment decisions. And then the third one is how well we respond to questions and complaints. And I wanted to show this slide because in addition to the key drivers being really important, reviewing every single comment is important too, because this is the voice of our patients. They are telling us what we're doing well and what we can improve on. And I generally see a lot of really positive comments about excellent care, the kindness that they receive, respect that they receive, listening, and a lot about teamwork. And I love to see, you'll see a couple comments on there with people's name. And I love that because that means that the person made a lasting impression, just like how I remembered my physical therapist, Sean. So before I move on to show you some of the performance information, I want to talk a little bit about the employees who don't work directly with patients. I get that asked about a lot. How do they impact patient experience? And they absolutely do, because without the support that they provide, we can't do it. They support those who support the patients and are the caregivers. So ensuring that we provide the best patient experience possible, it truly is a team effort. So since I've been here, I've spent most of my time in the inpatient space. So I wanted to share some information about their performance. So the top graph shows the likelihood to recommend score starting in July 22nd at the beginning of the fiscal year. And the gray line represents the goal. And I can tell you this organization has very high goals, which is good. And the green line represents the likelihood to recommend score. So in March in 2023, 80% of the patients said they would definitely, yes, recommend Washington to their family and friends. That's really good. And so the bottom graph, this is what we call percentile rank. And this is also important because it shows how we compare to other organizations in Press Ganey's really huge database. So in March, we were in the 85th percentile, which again is really, really a strong performance. And you can see from the trend line, it's going in the right direction. And so you probably noticed on that slide that there was a nice improvement in March of 2023. And that's really because there were some units that performed really, really well. And one of those units is 6 West, and they went from a 72.6% to a 90.48 mean score for likelihood to recommend, which again, that's fantastic. And that put them in the 99th percentile, like at the very top. So that is truly incredible. And you can see it just continued to slowly increase. I've been spending a lot of time rounding and shadowing on this unit because I know they've been very focused on improving the patient experience, and you can see their efforts are working. And I wanted to pull data by quarter so there was a larger N size, and you can see that Q3 showed a really nice improvement. And then listed on the side of this slide are the efforts that this team has made. And my hunch is that implementing and auditing the bedside shift report is really having a large impact. And bedside shift report is a conversation between the offgoing nurse, the oncoming nurse, the patient, and the family at the bedside. And so this is really that ideal time to demonstrate courtesy and respect, to demonstrate listening, clear communication. And bedside shift report is an evidence-based top tactic improving the patient experience. So tele is another unit that we have seen significant improvement the last quarter. They jumped all the way up to the 95th percent or the 91st percentile. And this unit has been focused on rounding, particularly leader rounding and hourly rounding, which is another top tactic and incredibly important for improving patient experience. And you can see there were some really positive comments coming from that unit, including this one, which I really liked, that stated, "The nurses were very kind and communicated with me. I know that I'm not an easy patient. This is the best day I've ever had." So transitioning to communication, I wanted to share with you this slide that shows examples of the process owner boards. And I have to admit, I was really excited when I was rounding here the first time and I saw these boards on every single unit, on every single department, and then realized that they were in all of the clinics as well. And I really like this because the boards include the performance metrics, including patient experience. And that information is shared during huddles. And this really ensures that leaders and the frontline employees are aware of their performance and what the improvement plans are. And like I said, the boards are not only on the inpatient units, but they're also in other service unit lines as well. Here are examples of boards in infusion, wound care, the women's clinic. As I think you can all know, communication can sometimes be a challenge. And this effort really helps us with consistency, and it is an expectation. So to wrap up, I would like to thank the board for making patient experience a priority and including it on the strategic map. During new employee orientation, I was pleased to see that patient experience was listed in 4 different areas. I even took a pen and circled it and was like, wow, that's impressive. So I want to conclude with my favorite quote. It's by Maya Angelou, and it reads, "I have learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And here we are committed to making connections with our patients and families, and we'll continue to do our best to ensure our patients remember how we made them feel. And so to circle back at the beginning of the presentation and my experience at Maui Memorial Medical Center, I left feeling like they knew me and they cared about me by providing, one, an endless supply of graham crackers and Diet Coke. I felt like they heard me and they listened by giving me the appropriate amount of pain meds and calming my fears about flying back to Phoenix. I felt like they taught me important information when they explained how to take a shower, how to wear the back brace, how to put on pants and socks. I felt like they coordinated things for me by demonstrating teamwork during transfers and bedside shift reports. And lastly, I felt like they made it easy for me with efficiencies, like having my medications in my hand when I was discharged. So I just want to thank you again for giving me the opportunity to provide you with patient experience information. And if there's time, I'd like to ask what questions you have for me.
Interesting to see all that you're doing. It makes you almost excited to go to the hospital. At any rate, thank you very, very much. We'd invite any of the board members to ask questions that they'd like to do.
I don't have a question, but I've got a comment, and I wanted to thank you for presenting Maya Angelou's quote, because it is one of my favorite quotes, and it's extraordinarily powerful if you understand the message behind that quote. Because when we experience something, it's stored in different parts of our brain. But how you feel is stored in the emotional part of the brain, which is probably the one that binds us most to the individuals around us. So what we do or what we say are easily forgotten, but patients will always remember how they were made to feel. And it is critical to our responsibility to do our best to help provide them the reassurance, the understanding, and our limitations in what we can do for them. So thank you for bringing that quote. I think that is an extraordinarily powerful message that we need to drive throughout the institution.
Thank you.
No question. I just want, again, to say how glad we are that you're here.
Thank you so much. I am so
Yeah,
glad to be here.
Glad to have you.
Again, Laura, thank you very, very much. It truly is really exciting. Very exciting. I joked earlier that it makes you almost just go to the hospital. We all know that's not true. This is a very, very difficult place to be. Anytime you're sick enough to be in the hospital, you need all the support you can get, and you need to be treated, as Dr. Nicholson so well said. You need to be treated in a manner that will leave you as well as possible. And the idea that you've been cared for, treated well, done everything possible to come back out in good condition. Thank you again very much. This is exciting program.
Thank you.
Have a good evening.
Thank you, Laura.
Okay, thank you.
The next item of business here tonight is our medical staff report from Dr. Hyder. And Dr. Hyder, are you with us? There he is. Dr. Hyder, we're ready for the medical staff report.
Thank you so much. Good evening to all, to all the board members and the directors and Ms. Harts. First of all, the physician number in the April month is total is 608, with anesthesiology 29, family medicine 45, medicine is 265, OB-GYN 32, pediatrics 59, radiology 47. So the active members are 339 with 1 administrative, and advanced practice provider is 38, ambulatory is 98, consulting 7, courtesy is 26, leave of absence at this time is 2, and provisional active are 48, and provisional APP is 25, and provisional consulting is 10, and provisional courtesy is 14. So the grand total is 608. And I want to remind that Dr. John Aiko, his memorial service is scheduled for this Saturday, April 15th, at 1 o'clock in San Mateo in Grace Lutheran Church. And the dinner dance date has been fixed, and it will be June 10th in Pleasanton, Castlewood. And the entertainment committee is working on it, the Genian and others. The election nomination for the medical staff has been, we have received, and the election will be in the month of May. It will be by Survey Monkey, the ballot will be sent, and within 2 weeks they have to return it. And this is my report.
Thank you very much, Dr. Hyder. Appreciate your report. Could you repeat the date of that dinner dance for me?
Dinner dance is June 10th.
June 10. Thank you very much. We
Thank you.
appreciate your report tonight. Looking forward to the dinner dance.
Thank you. Thank you.
We'll move now to our lean report. Kimberly, could you introduce that, please?
Yes, it's my pleasure this evening to introduce Anna Lynn Cisneros. She is the Quality Assurance Manager in Quality. She obtained her undergraduate degree in nursing from California State University, East Bay in Hayward. She completed her graduate degree with an emphasis as a clinical nurse specialist from San Francisco State University in San Francisco, California. Anna also received her doctoral degree with a focus on executive leadership from the University of San Francisco. Currently, Anna Lynn is the Manager of Quality Assurance for Washington. She has been at Washington for 14 years and has held various roles in the organization, including Staff Nurse 2, Charge Nurse, and Nursing Supervisor. Anna Lynn was also part of a multidisciplinary evidence-based pain management improvement project on surgical patients. When Anna Lynn is not at work, she is her children's biggest cheerleader when it comes to their soccer activities. And so this evening, Anna Lynn is going to be talking about the reduction of congestive heart failure readmissions. All right, Anna Lynn.
Thank you, everyone. Let me just pull up my presentation here. So thank you again for, as a lean certification candidate, for the opportunity to showcase some of the improvement work that's been happening around congestive heart failure readmissions. To provide some background information, heart failure is a condition where the heart
is not pumping and supplying enough blood and oxygen throughout the body as well as it should be. Currently, there are about 6.2 million adults in the US that have heart failure. In addition, heart failure hospitalizations rates continue to increase with an average annual percentage rate of about up to 4.3%. In addition, the cost of heart failure in 2012 was $30.7 billion, and it is projected to more than double by 2030, up to $69.8 billion. So in 2012, the Centers for Medicare and Medicaid Services, CMS, launched the Hospital Readmissions Reduction Program, known as HRRP. As part of the Affordable Care Act, HRRP encourages hospitals to improve communication and care coordination to better engage patients, families, and their caregivers in an effort to reduce avoidable hospital readmissions within 30 days of discharge. Congestive heart failure being one of the conditions that was costing CMS billions of dollars each year was included as part of HRRP. HRRP impacts the bottom line of the hospital by reducing Medicare payments up to 3% for excess readmission rates. And as far as Washington Hospital's CHF readmission rate, from July 2021 to June of 2022, the heart failure readmission rate was 26.4%, which is higher than the CMS national readmission rate of 21.3%. And lastly, as a lean candidate, we used an A3 problem-solving method to really understand and get to the root cause for why our heart failure readmission rate increased. An A3 is basically a lean methodology or structured thinking and problem solving. It is a scientific method that helps us manage improvement projects by not jumping into solutions. An A3 also provides the team with strategies to address our problems, but also embraces out-of-the-box solutions, keeping in mind data-driven decision-making. And lastly, an A3 communicates complex cross-functional information on a single sheet of paper. The key elements of an A3 consist of understanding the current state, defining the problem, defining a goal that is specific, measurable, achievable, realistic, and timely, or SMART, helps us identify to understand the root cause, key drivers or high-level concepts that we think would impact the root cause, and countermeasures, which are specific interventions within the key drivers to help us work on the goals that we make, and lastly, a plan for sustainability. This is the current document that we created for as an A3 that helps us identify how we are working on our heart failure readmissions. You can see the content here includes the problem, our SMART goal, understanding our current state, and really the key drivers and the countermeasures and the sustainability plan. When we look a little bit deeper, the problem that we identified when it comes to heart failure readmissions is that there are variabilities and challenges in hospitalized congestive heart failure patients. Inconsistent care coordination and communication among the care teams really impact the quality of life for our heart failure patients. And these variabilities have led to patients coming back more often than they should, which have also led to inadvertently increased readmissions and in some cases, payer denials. In alignment with the hospital's operational priority to improve care coordination, the A3 that we created sought out to reduce congestive heart failure readmissions from 26.4% down to 21.3% by June 30th of 2023. The next thing that we did was really understand the current state. So the team and I really looked at the entire process from beginning to the end, really looking at when the heart failure patient comes through the ED all the way to after they've been discharged. From there, we were able to understand the things that were happening for the patient and the things that were not happening for the patient and really understand those gaps. We then used a couple of tools known as the fishbone diagram, which is a cause and effect diagram, to categorize some of the gaps we identified. And then we also used this tool called the 5 whys. So really asking ourselves the question why 5 times to understand the reason why things were happening. After we did an analysis, we developed our key drivers and we came up with what the key things that we felt could impact our heart failure patients in their readmissions. We felt that if we managed their condition during the hospital stay, involved transitional care all the way from the beginning and throughout their hospital stay and even after, addressed patients' concerns not related to heart failure, such as food, housing, transportation, and lastly, provided concise education for the patient, then those are the things we felt could help reduce our heart failure readmissions. These here on the right side are some of the interventions that we have implemented and are still working on. When it comes to managing the patient's hospital stay, we've been able to work with our providers to update our congestive heart failure order sets. When it comes to transitional care, we have ensured that patients have a primary and specialty care follow-up appointments prior to discharge. We've worked with frontline staff and the IS department to collaborate on concise CHF standard education for what will be given to patients as well as appear on their after visit summary. And really, we've also tried to develop and strengthen our relationships with the community when it comes to home health agencies and skilled nursing facilities. And that's what we call our high quality network. This way, we'll be able to follow the patient through the entirety of the continuum of their care and be able to work with them even after they've discharged from the hospital. So what is the impact of everything that we have worked on? Well, you can see here that we have our baseline data of a 26.4% readmission rate. We have the yellow line being our target of 21.3%. You can see here some of the various things that have been implemented. But you can see here that since September, there's been a gradual decrease in the number of heart failure patients. And you can see that since November, we have consistently been below the target of 21.3%. And when we look at our readmission rate stemming back from July 2022 through February 2023, we remain below the target at 17.3%. So our next steps at this point include implementing the remainder of the countermeasures when it comes to reducing heart failure readmissions and really developing our sustainability plan with the things that we have put in place thus far. I would like to open up now for any questions that anyone may have regarding heart failure readmissions. Thank you.
Very much, Madeline. Are there any questions or comments from the board at this time?
Yeah, Annalyn, thank you very much for your presentation. I have a question on the denominator on the numbers that you presented. They seem rather small. Is that just Medicare patients only, or a sampling of Medicare patients, or does it include the broader spectrum of patients who are admitted with congestive heart failure? What defines the denominator of the data that you presented?
Thank you for asking. Unfortunately, yes, the scope of this project is limited to our Medicare patients. We are monitoring readmissions, though, internally as a whole for more than just the Medicare patients, but the scope of this project included just the Medicare patients that were under heart failure.
And another question, when you refer to Medicare patients, does that refer to straight Medicare patients, or does that also include Medicare Advantage plans?
In this case, this is the straight Medicare patients.
All right, thank you very much, Annalyn.
Thank you.
Other questions at all? I want to just congratulate you on the progress.
Thank you.
Very nice to see that kind of progress, and that's a tremendous amount of work that's involved in that.
There is a lot of improvement work that has been going on, and we hope to implement this throughout the organization with other conditions.
Great. Thank you very much. And again, appreciate you and appreciate the report. Hopefully it'll all continue and onward and upward.
Thank you.
Now, our next report is our service league report from Sheila Vijay.
Good evening, everyone, and to the members of the district board, greetings from all the volunteers. Here's my report. For the month of March, 179 Service League volunteers contributed 1,967 hours to the hospital. We hosted a Saturday orientation in March, attended by 3 high school students, 12 college students, and 5 adults. I'm also pleased to bring to your attention 2 more volunteer programs. In recent months, we have begun a partnership with Fremont Unified School District that brings students from the special education program into the Service League. These adult students take continuing education courses through the school district and are placed in workplaces and volunteer positions. These volunteers assemble urine test kits and patient welcome bags for the Service League. In March, they assembled around 250 urine test kits and 100 welcome bags for medical oncology. The students are accompanied by their resource specialist who is learning about the volunteer opportunities available for the students that they support. The second volunteer program is Mended Hearts. Mended Hearts is a national and community-based nonprofit organization founded in 1951 by Dr. Dwight Harkin, a cardiac surgeon. Its first members were 4 of his post-surgery heart patients. Mended Hearts has an accredited visitor program that consists of patients themselves who listen and share information about living with heart disease from the perspective of someone who's been there. Currently, we have 2 volunteers making their patient rounds at our telemetry department as accredited visitors. I recently had the opportunity to shadow Harry Lorsbach, our volunteer and president of the Fremont Mended Hearts chapter. It was really wonderful to watch him interact with our heart patients. Harry's passion and interest in what he does really showed through to me, and I do believe to the patients as well, because they were very comfortable talking to him. In our March, our Mended Hearts program in March, the volunteers talked to 40 heart patients in the hospital. They also interacted with 20 family members or caregivers. And that's all I have for you today. Please let me know if you have any questions.
Sheila, it's really fun to see the Service League tooling up and getting more and more involved and more busy after the COVID.
Absolutely. Thank you, Dr. Stewart. And I hope in the future meetings, I'll be able to highlight some of the areas that we volunteer. I usually bring numbers and the number of volunteers that work for us, but what I would like to do in future is to highlight specific areas so the community and the board, the district board knows where, whose lives we are touching.
Thank you. That would be wonderful to see. It would also help, I think, in recruitment. and bringing more people in to serve on the service league. It's a great, wonderful organization, and we really appreciate the work you're doing.
Thank you, Dr. Stewart.
Any questions from the board? Thank you very much again, Sheila.
Thank you.
We're now ready for our next report, which is a quality report from Dr. Diane Martin.
All right, I know that we're all very familiar with Dr. Martin, but she is here this evening to talk about the antimicrobial stewardship program, and I'm just going to do another introduction of her. Dr. Diane Martin is a member of the Washington Hospital's medical staff since 1984. Dr. Martin has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection prevention. Dr. Martin has been a physician champion for our 5 Million Lives campaign, where she analyzed data and educated her peers on infection prevention issues, especially MRSA. Dr. Martin is currently the co-chair with Lena Wong for the Antimicrobial Stewardship Committee and co-chair with Gulnaz Hanif for the Infection Control Committee. Dr. Martin also served as one of our key leaders during the peak of COVID response planning, a role that she continues today. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine, and she now serves on the board of directors of Life Elder Care, and she's a member of Washington Township Medical Foundation.
Thank you. Shri, you're going to drive the slides for me. Thanks. Okay, so I want to go over just some of the highlights of what we do. It's fairly extensive, and so I'm just sort of picked areas that I thought would be appropriate to discuss. So the agenda for this topic is going to be to describe how resistant organisms are a global health threat and how the antimicrobial stewardship can help with reducing the emergence of resistant organisms. We're also going to list the Joint Commission standards, which guidelines are for our antimicrobial stewardship program. So a Joint Commission is a nonprofit organization which helps with accreditation of US-based healthcare facilities, hospitals, and other programs. So it's the guidelines that we use for setting the standards for, or the parameters for our programs internally within the hospital and the hospital as a whole. And then the other thing I want to go over is how to explain interventions and the outcomes that our antimicrobial stewardship has been able to help with. Next slide. So our goals for going through what we're going to talk about tonight is to promote the appropriate use of antimicrobial agents, decrease the risk for development of resistance, decrease the spread of infections caused by resistant organisms, and improve our patient outcomes. So the bottom line is our sort of mission statement. So mostly what we're using is protocols to help, guidelines to help physicians and staff use appropriate antibiotics in the right place for the right drug at the right time, and therefore minimizing resistance, which would impact patient care. Next slide. So antibiotic resistance occurs when an organism develops a mechanism to defeat the antibiotic designed to eradicate them. And organisms are very smart, so they want to figure out how to avoid something that's going to get in their way of doing what they like to do, which is promote infections. This is a global challenge for modern medicine because we're used to using antibiotics pretty rapidly, because in the last 20 to 30 years, there have been more and more antibiotics. So when one became sort of ineffective, we had another one to turn to, but that's not the case anymore. The other thing we saw was resistance spreading much more quickly, even across the globe, when we were seeing COVID-19 infections. People were quite a bit more ill. We were using more antibiotics, and we were also starting to see worsening resistance patterns. We also see the effect of modern medicine. So modern medicine has provided us with chemotherapy, organ transplant, very meticulous surgeries, dialysis for outpatient patients universally. These also put patients at risk for infections. So we want to look at that in great detail. We also want to look at resistant organisms which make antibiotics ineffective and therefore result in negating the benefits of the modern medicine. Next slide. So everything kind of works in tandem across the board. So this is just a picture showing you what happens when there is resistance. So if you're looking at the left-hand side, you're looking at the green bugs, which are the ones that are sensitive to antibiotics. You see the one blue one, that's a resistant one. So what happens is the antibiotic kills off all the bacteria except the resistant one. Then the resistant one begins to multiply, forming a population of antibiotic resistant bacteria. And then that antibiotic bacteria can then pass the DNA synthesis for antibiotic resistance to another bacteria. Therefore, the other bacteria can mutate and then become resistant. So you can see it starts with antibiotics being used, and if we're using them appropriately, hopefully we don't promote the resistance of that one particular bacteria that is resistant, and then starts to propagate and becomes more resistant across the board. So with antimicrobial stewardship, what we want to do is prevent unnecessary use of antibiotics. So we want to use them appropriately where they're best needed and can result in best outcomes. We want to use them appropriately, the best dose and the best duration. So in other words, not using them longer than we really need to, which again would promote the development of a resistant bacteria. So this helps reduce the development of resistant bacteria and therefore prevent the transfer of the resistant gene to other bacteria. And that we do in collaboration with another program called infection prevention. Next slide. So this just talks about the Joint Commission promotes the quality standards for hospitals. And one of the standards is antimicrobial stewardship. So the standards on this one is a little bit challenging to look at, but mostly what we're making sure is as a group, we have enough financial resources for the staffing and for the IT to support this program. We need physician and pharmacy leaders, which we have. The leaders also help implement hospital-wide stewardship programs. And we do that through our team. Our team is multidisciplinary. So we have pharmacists, we have lab, we have physicians, we have quality, we have compliance. So that it's a very interdisciplinary committee, which then reached out to the other departments to pass on the information, the suggestions, the monitoring, and our protocols. So what we do is try to get document evidence-based use of antibiotics in all departments. So we monitor what we call days of therapy. In other words, how many days the antibiotics are being used, which is also reported to what we call NSHN, which is National Health Safety Network, which is part of CDC. I'll get to that on another slide. So we want to implement one or both where the antibiotic is pre-authorized. So we have guidelines built into our order sets when a physician or a nurse practitioner or provider is looking to use antibiotics, then they're guided with the order sets, specifically which ones would be most effective and would be used best appropriately. We also look at prospective review. In other words, a patient who has a positive blood culture, we want to give the physician or the medical provider guidance as to which antibiotics would be most appropriate, given that we don't have a specific answer when you're first starting out. And then once you get more information, in other words, we get what the culture is, what the sensitivity is, then you can guarantee you've got the right drug for the right reason. Prospectively, what we do is we look at all of the infections that we have in our hospital, what the sensitivities are, and try on those information to make recommendations. And again, this is in the order set, making recommendations that a physician or medical provider can use to choose antibiotics for their patients. So we're going to implement they want us to implement at least 2 evidence-based guidelines, and I'll go over 2 of them that we have been working on. We're working on several, but 2 that I thought you'd be most interested in. Then we evaluate how well there's adherence to these evidence-based guidelines. So it's one thing to put it out there, but we want to see what's the response. Are the physicians or the medical providers using them? If they are, do they find them helpful? Are we getting the outcome that we're looking for? In other words, the patients are being treated appropriately and having eradication of their infections. So we analyze the data and we report it to hospital leadership and prescribers. So we present this to a pharmacy department, we present it to the medicine department, the medical staff as a whole, family medicine, and also surgery departments. Next slide. So this lists the various team members on our Animal Stewardship Committee to show you how diverse it is. So we have a pharmacist leader, which is Lena Wong, me, who's the physician leader, but we also have other physicians on this that are basically infectious disease physicians who help that, and other medical staff to help guide, to make sure what we're recommending seems practical and realistic. We have infection prevention on there team, we have compliance. Another valuable resource is IT, because they look at our protocols that are then put into the order sets into our EPIC program, which is our medical ordering system, which is computer-based. We have laboratory microbiologists and a pathologist. We have pharmacy. We have great resources from nursing. So all of this combines to make a medical antimicrobial stewardship committee so that we can provide broad spectrum intervention from the participants so we make sure that it's applicable and practical. Next slide. So these are a couple of the evidence-based uses of antibiotics that we've been working on. One is our annual antibiogram. And an antibiogram is where we're reporting the amount of resistance per organism per antibiotic. It's like a big flow sheet chart that's available on our EPIC intranet. So both physicians, nurses, pharmacists, everybody has access to this, and it helps trend our susceptibilities. So we're looking to try to maintain, because again, there are very limited resources in terms of antibiotics. We don't have new ones coming along. So we want to make sure the ones we have available stay available for fighting off these infections. So the other thing the antibiogram will do is to include recommendations based on our susceptibility patterns. So we look at susceptibility, so which bacteria, germs, fungus are resistant to certain antibiotics in our specific organization to make sure we can recommend those that are susceptible. And that will change from year to year based on the resistance patterns. The other thing we do is to organize order sets, and those promote what we consider best use of antibiotics. So one that we use is called severe sepsis, and that's mostly when a patient is so acutely ill that they're needing to be either in the intensive care unit or the intermediate care unit. So this order set is for physicians and medical providers to guide them in terms of what you're looking for, either pneumonia, we're looking for bacterial infections in the bloodstream. We're looking for urinary tract infections. We're also looking at skin and soft tissue infections. So we created a critical care admission set and also ER order set so that when the patient comes into the emergency room, they're being assessed as needing antibiotics. The physicians or the care providers can assess what particular antibiotic would be most effective for that particular patient. We also more recently developed a maternal sepsis order set. So these are guidelines for women who are coming in that are pre-delivery or post-delivery that developed infections. So we want to guideline those specifically because we're looking at breastfeeding moms, women who have other issues that we need to take into consideration. Another area that we're looking at is surgical antibiotics. So a patient coming in for surgery, what antibiotics do we give them to prevent from getting infections? Or if the patient's coming in and has an infection and needs surgery, again, which antibiotic would be most appropriate? And those are in our order sets and guidelines. Another area that we've looked at is what we call IV to PO conversion. So IV means intravenous, because antibiotics can be given IV or orally. We think that, and it statistically has been shown that there's less resistance if we can switch from IV to PO and then decrease the number of days that the patient has an IV in place, which separately can also cause infection. So there's about 7 antibiotics that we have that are equivalent. In other words, they're just as effective IV as well as oral. Many times when the patient comes in, they're very acutely ill, they're not able to take oral, but as they begin to recover, they are able to take oral. So we're looking to make sure that those patients are provided the option for using oral antibiotics as opposed to IV antibiotics. The other area that we are working with is renal dosing protocol. As patients who have renal deficiencies or renal failure or on dialysis metabolize antibiotics in a different way. So we want to make sure that we're using antibiotics appropriately in terms of organ dysfunction for patients who have renal failure or renal compromise, to make sure that that antibiotic is used appropriately for those particular patients. Next slide. So NSHN, again, is National Health Safety Network, which is part of CDC. And they're the organization which trends antibiotic usage throughout the United States and provides analysis. So this is how we sort of look at things in general. So we take information across the board. So we're not only looking at just our data, we're looking at hospitals that are like area, in other words, suburban areas, ones who treat the same types of patients that we see. So obviously, once we get our trauma designation, we'll be looking at a slightly different profile. But currently, we look at the profiles that are provided by NSHN to make sure that we are looking at our antibiotic usage in the same way that other facilities and other hospitals, nursing homes are also looking at it. So our stewardship team will take that information, review what we're doing, and making sure that we can provide best care and feedback for our physicians and also for the nursing staff, the pharmacists, and ultimately to make sure we're doing best care for our patients. Next slide. This one's a little bit busy, but you'll kind of go with me here. So what we're doing with antimicrobial usage is we're monitoring our antibiotics by reporting to NSHN. And again, they're a national database that we look at. They look at different types of organizations, so we can benchmark ourselves against like to like and make sure that we are appropriate in our use of antibiotics and that we are consistent. So the thing that we're looking at is called SAAR, S-A-A-R, which is Standardized Antimicrobial Administration Ratio. So this is where we're looking to make sure that in terms of patient days, in terms of infection risk, that we are using antibiotics as expected or not as expected. So a 1, less than 1 is better than expected. A 1 is as expected, and greater than 1 is worse than expected. So this is across the last 2 years, starting in January of 21 all the way to the end of 22. And you see we're hovering right about that 1 line. So sometimes we're a little bit below and sometimes a little bit above. So in the past, we have been considerably higher. So in the last 2 years, we're hovering right at 1. So we think we're, as best we can tell, doing very well compared to what the national standards are, the national recommendations, what other facilities are doing as well. The little bit of upswing on the last couple of months was, again, we had a huge surge in our census, which tends to sort of drive the use of antibiotics a little bit higher than would be expected. So again, I think we're staying right within our trend line and doing generally well. So the next 2 slides talk about 2 projects that we have been working on. So we're looking at an antibiotic called piperacillin tazobactam, which is a very broad spectrum antibiotic. So it works well for gram-positives, which is like staph infections, strep infections, as well as gram-negative infections, which is like E. coli, Klebsiella, which cause more significant infections. So we looked at our use in general and found that about 15 to 20% of the use of piperacillin tazobactam, a very specific antibiotic for broad spectrum use, was ordered mostly for skin infections and seemed to be prescribed in the emergency room. Most of our ED patients are seen in the ED, evaluated, treated, and for the most part get discharged home. A smaller percentage are ones that do get admitted. So what we looked at was to try to collaborate with the emergency room to develop a skin and soft tissue infection treatment algorithm, which helps the ED doc look at the patient based on, are they diabetic? Are they on chemo? Are they dialysis patients? Are the skin infections fairly superficial? So not really red or pus looking, or is it, a severe infection where the person's been at home, not able to get in, and the infection's much more rampant. So we look at those parameters and help guide the antibiotic selection based on those parameters, based on national guidelines as to what is the most appropriate antibiotic. And again, we're looking to try to use the best antibiotic for the right reason for our patients to get them treated. And we want to make sure we're not overusing or underusing or prolonging use. So what we did was then to share the treatment algorithm with the medical staff to try to get feedback. Because sometimes you're looking at something and I'm so focused on something and I may not be taking the whole picture into perspective. And again, sharing with the medical staff, we get perspective from the physicians who are treating patients on a day-to-day basis to say, that algorithm works, but I think you could tweak it and make it better by doing this. So we try to get feedback. So we're at the same time educating, but looking for feedback at the same time. So just as Annalyn was talking about a SMART goal, we use the SMART goal because it talks about very specific measures, which is what the S stands for. We look for, is it measurable? In other words, can we see actually where we're going, how can we make it better? We make sure it's achievable, because it's not realistic to use a goal that you say, I can't achieve that. In other words, if we're using 20% of pip/tazo, it's not realistic to think I'm going to go down 5%. So we want to make sure it's achievable. We want to also make sure it's relevant. In other words, are we treating the patients that we see day in and day out? Make sure that they're treated appropriately. Make sure we can get them home, or if they're in the hospital, make that stay as nice as Annalyn makes it, make it as short as possible to make them happy. We also want to make sure this is time-based. That's what the T of the SMART goal. In other words, use this in a time-based thing so that we're using it in rapid time, making sure that we're implementing changes appropriately and not delaying things. The next slide talks about a different antibiotic that we're using, vancomycin. And vancomycin is primarily used for gram-positive antibiotics. So the other one, the pip/tazo, is used for gram-positive and gram-negative. So gram-positive, again, is your staph and your strep. So we wanted to identify areas that we could result in some improvement. And we were able to do that. And then once completed, we were able to share our recommendations. So with the recommendations, approximately, we found that 40% of our vancomycin were again being used for skin and soft tissue infections. And what we want to do was optimize that to patients who had very severe infections and use our lesser antibiotics for patients that did not need such strong antibiotics. So what we were able to do is update our guidelines and also working with the emergency room, update treatment algorithms. So when the physician's looking at a patient in very short fashion, they can assess the patient, see what the parameters are, see what the guidelines are for the particular antibiotic. Do they need to be admitted and only an IV antibiotic is going to work? Or is this a patient who could be treated with oral antibiotics at home And if yes, which antibiotics would be the best for that patient at home? So we shared the guidelines with the medical staff, again, getting feedback. And our goal is, again, to decrease the vancomycin to less than 1 by the quarter ending of 2023. So then again, that's our SMART goal. So it's specific, measurable, appropriate, relevant, and time-based. So this is going to be an ongoing project that we're looking at. So the final slide is talking about key takeaways. So with our antimicrobial stewardship program, we've been able to reduce the resistance that we've been seeing. We actually, and very interestingly, it's on another slide that I didn't bring. One of the antibiotics that has been very commonly used is what's called a quinolone, which is levofloxacin or ciprofloxacin. And what we actually saw is because of such common use of that antibiotic, we were getting more and more resistance. With working with the physicians and the pharmacists and the nurses, we have actually been able to turn that around by about 20 to 30%. So we had dropped down quite a bit to where we're seeing probably about 50% resistance. Now we're back up to about 75% resistance, which makes a huge impact when you're trying to decide what to do in terms of treatment, because those antibiotics are very good in terms of being able to switch from IV to PO, because again, it's one of those 7 that's a bioequivalent where you can use it IV and then switch to PO so the patient can go home and be appropriately treated. But we're able to see improved effectiveness because we're using it very specifically for appropriate infections and appropriate patients. So with this, our animal stewardship program works to preserve the power of our currently available, because again, there are very few antibiotics that are actually being manufactured that are new. What we're doing is just trying to promote the power of the antibiotic longer, more specifically of what we actually have. So the data analysis of antibiotic usage, which I showed, provides information on how to prioritize our stewardship interventions and action plans. So it shows us where we can best use them and then share that with our medical staff, nursing staff, and our medical providers. So with that, I'll take questions.
Thank you very, very much.
You're welcome.
I think this presentation has tremendous value and is very, very important for all of us, and particularly the general public to understand. I'm afraid that most of us...
Well, it's certainly a task that I could not do without the support of the pharmacy staff and the leadership of the physicians, because, you know, a lot of physicians can say, oh, I want to do it the same way I always do it. I don't want to change. So they have been very receptive to change, and I could not do what I do without Lena Wong. I mean, she's my go-to person when I get stuck with stuff. And she's also very helpful in terms of formatting a lot of what we see and making it user-friendly in terms of the information.
Really wonderful to hear. I'm afraid that most of us feel like the battle against the microbes and everything, it was won a long time ago with antibiotics. And in fact, as you presented tonight, the battle rages. We're not winning totally. We're not losing, but it's a battle that needs to continue every day, and every patient that comes into the hospital and every patient is treated outside of the hospital. It is truly a battle, and
it's a trend we're hoping to turn around.
You presented that in a way that shows that we're just as strong as they are. And we're going to win this.
I hope so. I truly hope so. Thank you.
I really appreciate your presentation tonight. It's very, very
Thank
informative.
you. All right. Thanks for the opportunity, because I hope we can this way reach out to our community as well and let them know what we're doing behind the scenes to kind of make our hospital as strong as we can, make sure our antibiotics are as relevant as we can, and also make sure that our physician team, our our pharmacy team, our nursing team provides support for our patients, so they know that they are well cared for in our hospital.
And thank you very much.
Okay, thank you.
Are there any other comments?
He's gotta go. Thank you.
Okay, all right,
Yeah,
thank you. I'm going to sign off.
I have a question.
Thank you.
Dr.
sorry.
Dr. Martin, hold on. Dr.
Yeah.
Martin, Dr. Nicholson has a question. Hold on one second.
Okay, I'm here.
Barney,
I'm here. Thank you.
Back to your comment about that it's an ongoing battle. It's actually trench warfare.
Yeah.
It really is. And it's got to be fought patient by patient, provider by provider. Diane, my question is can you tell us a bit about what the antibiotic stewardship program is doing to help guide us as far as the optimal duration of a course of antibiotics? I'm beginning to think that the golden rule of antibiotic stewardship is less is more.
So you point out a very good goal for us, and it's one that we're starting to work on. It's been quite challenging. We have a number of options that we want to look at in terms of skin and soft tissue infections, also our sepsis infections and pneumonia. So we are working on that right now. We don't have anything quite framed up, ready to go in terms of sharing with our medical staff and our medical providers and stuff, but it's definitely something, you've touched on something we really, really want to do. We're working on that as our sort of 2023 project. So hopefully the next time I present to you, I'll be able to give you that answer. So thank you for making it a priority. We really want to do it.
I'm glad to hear that's on your radar.
Thank you.
Again, Dr. Martin. I appreciate all you're doing.
Okay, thank you, thank you. I'm gonna sign off, but you can always call if you have questions. Thank you.
Thank you, Dr. Martin. Thank you, Lena, too, for all of your work.
Our next report will be our finance report. This will be the first finance report from our new Chief Financial Officer, Tom McDonough. We appreciate you being here. It's fun to hear from you. Kimberly would, as an introduction, she'd like to make.
Yes. Thank you, Dr. Stewart. As I think we've mentioned in the past, Chris Henry, our Vice President, Chief Financial Officer for many years, will be retiring this month. So we have Thomas McDonough that is here, that is now taken over as Vice President, Chief Financial Officer. And so I'd like to just give the board and the community a little bit of an overview of Tom. Tom joined Washington Hospital Healthcare System in February of 2023 after working the last few years for 2 tribal health systems in Alaska and a rural community hospital in central Washington. Prior to that, Tom worked 22 years with Providence Health System. For the last 7 years with Providence, Tom served as their CFO of Shared Services and SVP Treasurer. Tom graduated from Washington State University with undergraduate degrees in economics and finance. His graduate degree focuses on business analytics and administration. As CFO for Washington, Tom has accountability for accounting, audits, revenue cycle, payroll, payer contracting, treasury, financial planning and analysis, budgeting, and benefit programs. Tom is an active member of many of the associations around finance, including Healthcare Financial Management Association, Society of Human Resource Management, Association of Financial Professionals, American Finance Association, National Investor Relations Institute, National Venture Capital Association, and CFO Leadership Council. So welcome, Tom, to Washington, and turn it over to you.
Thank you. Well, Dr. Stewart, as you said, this will be my first one, so I may stumble a bit. But I'd like to start off just by kind of overviewing the documents that are already in your packet, and that is February, we wound up with a net operating income of a loss of $63,000. So what I thought I'd do is dive into the details behind that and talk about some of the key factors behind the $63,000. Does that sound appropriate?
Absolutely.
All right. So our inpatient daily census, we had a budget of 160.5. We had an actual of 167, so about 4% over budget, if you will. Our combined average daily census, and remember this is taking the inpatient and the observation and combining them. We had 176.5 versus 172, or about a 2% increase in the combined daily census. Admissions were up about 10.5%. As you can see, we had 866 on a budget of 784. Patient days were about 4% higher than budget at 4675. And then the observation days, we had a budget of 329 and our actual was 265. Finally, our average length of stay, this has been a journey, as you know, after COVID, when it really skyrocketed up. And so this journey is still in progress, but we continue to chip away, and we're looking at 556 as our actual length of stay versus a budget of 573. And year to date, we're at 548 versus the 563 on year to date numbers for there. Moving ahead, our case mix index, we had a budget of 160, we were at 1589. So a lower case mix, as you know, does impact the level of reimbursement. So a little bit lower acuity, but not much. Year to date, we're at 155 versus 160. Deliveries, we had about 107 on a budget of 110, small decline. Surgical cases, this is the rarity that Chris mentioned, I think, a meeting or so ago. We had a budget of 344, and we had 344. So we're right on budget there. Cath lab continues to be a bit of a struggle here, as we are one physician down. We're in the process of recruiting, but we had a budget of 223, and we had 172, or 51 short. Outpatient visits were up 334. And then emergency visits continue to outpace our budget at 4424 versus 4350. And year to date, we're 2,500 visits over our budget, or about a 6% increase in ED visits. Utilization, we talked about the surgical cases, 344. The breakdown of that is joint replacements. We had a budget of 142. We had 157 actual. On the neuro and the cardiac, a little short at 24 of 32 and 11 on a budget of 14. So some of these were procedures that got rescheduled due to COVID, or we had PTO by one or more of the physicians. So that explains the difference there. But here again, we had 15 increase on the joint, and if you look at the neuro, cardiac, and other surgical, that's 15. So it was an even balance there in the utilization. Cath lab, we've already talked about, we're off by 51, and then the detail there is we're down across the board, but that is why we're working and putting a lot of effort into physician recruitment there for the replacement. Okay, moving ahead. I have,
wrong way.
Thank you.
Gotta hit the forward button.
Our productivity FTEs, we were over on that by 30.2. Some of that is explained by remember the increased volume that we saw, right? But the non-productive FTEs, we were under by 9. So that is positive to the budget. And then finally, one of the key measures that the outside investors and rating agencies look at, and that we look at as an organization, is the FTEs per adjusted occupied bed, right? So that tells us how productive we are, efficient, and the cost that's going into that patient and the overall operation. So here we have 566 on an actual on a budget of 623. And year to date, we're at 602 versus a budget of 630. So again, some slight variability, but overall it's improvement, and that is good for expenses overall. I don't have that one next. I have the deductions first, Chris. Would you mind going to the deductions?
Okay.
Here we go. Okay. So we talked about gross income was at 188 million, and then we have the contractual allowance at 143 on the actual. So about a 76% contractual discount versus a 75.25. So gross was up about 2%, but contractuals were higher than budgeted. So that difference creates some of that pressure on the net operating income that we talked about earlier. Then we have provision for bad debt. That was also over budget, so 4.3 versus 3.6. You add that together and we have total deduction of 147 or 78.25 versus 77.14. So that 1% there creates that difference. So the reason I bring that up is if we move, now go back to the, thank you, sir. These are the numbers now that you see on this slide for the GASB report. So 188, meaning our net operating and the contractual reductions. Net operating revenue is 43 million on a budget of 43.5 million, or a difference of 507. Then you had operating expenses of 4304 on a budget of 41.7. So a difference of 1.3, and combined the operating income was off budget by 1.9 million, but only a $63,000 loss for the month. If you look at the year-to-date numbers, operating income were positive 4.2 million, or a NOI percentage of 1.2%. And on a budget, though, of 14.4 or 4%. So we do trail budget, but we are positive year-to-date through February. The one thing I'll point out down here at the bottom, under the, below the operating margin section, the expense, if you will, is the unrealized gain loss is 1.7. So, and the reason I point that out is this is how the government would like to have their reporting done. If you go forward, Chris, now, you'll notice some of the numbers have changed when we start looking at FASB, which is essentially what the investors, the rating agencies, and other non-governmental hospitals use for their reporting. So the top, you'll notice some slight changes in the operating income. We said it was a negative 63,000. It is now a negative 588 under FASB. So a negative 1.4%. And you can see the year-to-date numbers are also negative at 0.1, as opposed to a positive 1.2. Some of the reasons being that when we look at FASB, and I believe Chris has explained this to you a number of times, but the unrealized gain from investments gets removed. The property tax revenue and the interest expense now get moved up to the top. Does that make sense? Okay. So then we look at the bottom where we have those expenses, and without those charges being listed there, now you can look at non-op income of 419,000 for the month on a budget of 1.3. And the net income, so this takes operating income and non-operating income, combines it and says, what is our net income? It is a negative 169 or 169,000 compared to the GASB report, which says we're at negative 1.5 on a net income. And then as you look at the total for year-to-date through February, we're at 0.8 and 3.7 as opposed to 0.9 and 4.3. Slight differences. And then the board has always liked to see the EBITDA report. So EBITDA is basically the cash that is generated from operations, earnings before interest, depreciation, and amortization. And so, again, the numbers are going to look the same, but now we're calculating EBITDA for the month. So we were able to generate $3.6 million of cash flow from the operations of the hospital on a budget of 5.8. And year-to-date, we've generated 33.2 on a budget of 44 from operations. So operating margin, again, for the month, we're 4.4 off. So we're negative 0.2 on a budget of 4.2. And then year-to-date, we're at 1.2 versus a budget of 4. Total margin, again, after you take the non-op pieces and the net income, we're sitting at a negative 3.4 for the month on a budget of 6.7, and a year-to-date actual of 0.9 on a budget of 4.3. So we are trailing year-to-date in those financial indicators. And with that, I'll stop and see if there are any questions.
Looks like there are no questions. We appreciate your report. We look forward to working with you on an ongoing basis, and good things will come to pass, I'm sure. Thank you very, very much. Now move to our hospital operations report. Kimberly.
All right, thank you. You will see that we had a very busy March. However, we did have some challenges also with it. So gross revenue of $216.3 million for March was above budget by $24.3 million or 12.7%, and was above March of 2022 by $7.3 million or 3.5%. Inpatient gross revenue of $123.9 million was above the budget by 7.3 or 6.3%, and $2.5 million or 2% above March of 2022. Looking at outpatient gross revenue of $92.4 million was above the budget by $17 million or 22.6%, and $4.8 million or 5.5% above March of 2022. Also, want to just note that the Radiation Oncology Center had $4.1 million in outpatient revenue. This was not budgeted, and as we know, we started to run the Radiation Oncology Center in February under the hospital. In March, there were 35 COVID-19 discharges, or 6 fewer cases from the prior month, and 15 fewer than March of 2022. So moving on to the key census. The average length of stay of 5.48 was below the budget of 5.59 by 0.11 or 2%, and this was also lower than the March of 2022 length of stay of 6.01. So as Tom said, in terms, we continue to work on bringing this key metric down. Also, I just want to note there were 11 discharges with length of stay greater than 30 days during this month, ranging from 31 to 116 days. And excluding these outliers, the average length of stay was 4.90. And still in-house for the month, we have 7 patients with lengths of stay over 30 days, which range from 31 to 66. Looking at our outpatient observation equivalent days of 296, they were below the budget of 343 by 47 days and 21 days below March of 2022. And this is consistent with the trend we have seen this year in terms of fewer observation equivalent days. Inpatient average daily census of 165.7 was above the budget of 147.2 by 18.5 or 12.6%, and above March of 2022 of 164.5. So if you look at the combined average daily census, it was 175.2, and it was above the budget of 158.3 by 16.9 and 0.5 above the March 2022 combined average daily census. Looking at our admissions trends, our admissions of 906 were above the budget of 816 by 90 or 11%. March 2023 admissions were 105 or 13.1% above March of 2022. Saw the favorable variance is really largely driven by medical cases, and we also had a number of deliveries that you'll see. Looking at our patient day trends, the admissions and outlier patients are higher than expected, resulting in patient days of 5,138. This is above the budget by 574 or 12.6%. And patient days were 38 days or 0.7% above March of 2022. So just looking at that broken down, our adult medical surgical days were higher than budget by 341 days or 10.7%. Our OB, peds, and special care nursery days were higher than budget by 192 days or 48.5%. And our IMC days, 476 were higher than budget of 420 by 56 days. And just to remind the board, the favorable variance, especially in IMC, is consistent, and this intermediate care unit with a trend, and we've seen a conversion of some of the ICU beds to IMC beds. And ICU days were lower than budget by 2.6%. Looking at our surgical trend, our total surgeries of March was 395, and they were above the budget by 33 or 9.1%. And their surgeries were 47 or 10.6% below March of 2022. Inpatient surgeries at 154 were above the budget by 13 or 9.2%, but 13 below that of March of 2022. And then outpatient surgeries at 241 were above the budget by 20 or 9%, but 34 below March of 2022. Then moving on to look at our surgical activity broken down, you can see that our joint replacement surgical cases were above the budget by 39 or 26.7%, but were 20 or 9.8% below March of 2022. We did have 66 cases at the Peninsula Surgery Center in March. You can see also neurosurgical cases were running below budget by 8 or 25.8%. And were 8 or 25.8% below March of 2022. And then cardiac surgical cases were also below budget by 4 at 26, which is 26.7%, and were 3 below or 21.4% March of 2022. And then all other surgical cases combined were above the budget by 6 or 3.5%. Moving on to our cath lab trend. Again, still continue to have a challenging month. We are, as Tom mentioned, we are in the process of recruiting both for a vascular surgeon and also for interventional radiology, and those are two of the areas that we've been focusing on. So cath lab cases for March at 158 were 59 or 27.2% below the budget of 217, and 75 or 32.2% below March of 2022. Basically, our cath lab inpatient cases at 91 were 28 below the budget of 119, and also 19 below March of 2022. And cath lab outpatient cases at 67 were 31 or 31.6% below the budget of 98. And 56 below cases below March of 2022. You can see them on the next slide broken down by the types of cath lab activity that we saw. Basically, cardiac cases were above the budget by 1 or 1.1%, but were below by 1 in terms of March 2022. Really, we continue to see challenges in the non-vascular IR cases and peripheral vascular. IR cases, and if you look at both of those together, they were basically under budget by about 52%. Neuro IR cases were down by 2, and they were also down in terms of by 7 cases compared to March of 2022. As mentioned, our deliveries, we saw a spike in deliveries. We had, for the month of March, 143, which were above the budget by 31 or 27.7%, and 33 or 30% above March of 2022. So we both, that and our level 2 nursery was also busy for the month too. Moving on to our non-ER outpatient trend, we saw 10,059 visits that were above the budget by 1,463 or 17%, and above March of 2022 by 343 or 3.5%. This was really driven by a number of areas. We really have seen cardiac rehab visits over the last few months continue to grow. They were 56.3% or 345 cases over budget. We also had x-ray visits that were 208 or 12.7% higher than budget, and also OB visits that we saw were 85 or 55.9% above budget. And again, this also includes our visits from the Radiation Oncology Center, which we had 406 in March. Our emergency room continues to be busy. Emergency room had 5,069 visits, which were above the budget by 622 or 14%. And they were 867 or 20.6% above the prior year. So really continuing to see that very busy emergency room.
They said if you build it, they will come.
Yes, as I said, you know, it may be continuing to see people that haven't, you know, spent much time with physicians' offices and seeing them. We may see some of that. That's part of what may be happening. In terms of our gross revenue, surgical cases were above the budget by 33 or 9.1%, and revenue was above the budget by $3.4 million or 9.1%. Our room and board was above budget by $3.7 million or 10.2%. Patient days were higher than budget by 12.6%. And then our ICU days were lower than budget by 2.6%. As mentioned, our deliveries were above budget by 31, and revenue was, or 27.7%, and revenue was above budget by $1.1 million or 34.4%. We did have 52 C-sections in terms of for the month of March, which contributed to that. And we had a budget of 34. Our emergency visits, as mentioned, they were above budget by 14%, and revenue was above budget by $1.8 million or 15.4%. Cath lab cases were below budget by 27.2%, and revenue was $1.6 million or 12.5% below budget. We did have some late charges that posted from the last month, which was why we see the difference in terms of the number of cases versus the revenue. And then lastly, our ancillary services revenue was above the budget by $16 million or 17.7%, and primarily driven due to the outpatient activity that we talked about, including the $4.1 million from the Radiation Oncology Center. So again, a strong gross revenue month. However, when looking at our payer mix, it was not favorable. In terms of looking at our government-sponsored patient revenue, made up 75.7% of gross revenue. This was higher than the budget of 71.8% and higher than the prior year's percentage of 72.8%. Our HMO revenue, our HMO was 2.3% of gross revenue, which was lower than the budget of 2.6% and lower than the prior year's percentage of 2.5% of gross revenue. PPO was 21.9% of gross revenue, which was lower than the budget of 24% and lower than the prior percentage of 23.6%. Our private pay was 0.1% of gross revenue, which was lower than the budget of 1.6% and lower than the prior year percentage of 1.1% of gross revenue. So as mentioned, we did our government sponsored. That's it's the highest percentage we've seen in a long time. Yeah. Moving on to our preliminary productivity indicators. Our productive FTEs were above budget by 117.1 or 8.5% at 1,498. Our non-productive FTEs were above budget by 50 or 36.9% at 185.4. And total FTEs of 1,683.6 were above the budget by 167.1 or 11%. I think as you know, that we were very busy. However, we also had a lot of non-productive people out taking time off too. So really that contributed to the total FTEs being 11% over budget in terms of that. Now, as Tom talked about, our productive FTEs per AOB, really looking at that, it came in at 5.18, which is lower than the budget of 5.7 by 9.1%, but higher than the prior year, 5.01. And total FTEs per adjusted occupied bed of 5.82 was lower than the budget of 6.26 by 7%, but higher again than the prior year of 5.66 by 2.8%. So we did better than budget, but there's still room for us to be a little bit more efficient. Moving on to our preliminary outpatient statistics. The Washington Township Medical Foundation clinic visits were below budget in March by 2,199 or 10.7%, and 9.9% below March of 2022. This was driven by a couple of areas. Our primary care visits were below budget by 5.4%. We do have one open position that we're recruiting for in terms of primary care. And we had a number of physicians that were taking time off during this month. We also had specialist visits that were below budget by 7.3%. We have three areas that we're recruiting for: ENT, urology, and vascular. And again, we also had many physicians that were taking time off. Lastly, that makes up, we also have the COVID vaccine visits that it's in this number, and they were below budget by 899 visits, which is also contributing to this. I think we've seen the slowdown in terms of COVID vaccine visits. So it was hard in terms of difficult budgeting for that at the beginning of the fiscal year. Moving to the DevCo outpatient visits, we saw 2,402, which were above the budget by 199 or 9% for March, and 165 or 7.4% above March of 2022. You can see really it's driven by rehab center, our Washington Outpatient Rehab Center volume that was above budget by 210 visits. Surgery Center was pretty much right on budget. Our Peninsula Surgery Center was below budget by 34, and then Ohlone College was above the budget by 24 visits. So that. Again, looking at our key financial statistics, our days cash on hand for March ended at 149 days, an increase of 2 days from the prior month, and is 9 days lower than the same period in the prior year. The increase in days in cash is due to, we saw higher collections of $6 million, which was about 5 days. Our investment earnings we saw about $2 million, which is about 1 day. We did have higher operating expenses of about $2.7 million, and then we also saw our quarterly pension and OPEB contribution payments totaling about $2.7 million, which equaled about 2 days. So that's how we got to about increase of the overall 2 days. Our days in accounts receivable for March were 58. This is just slightly higher than the prior month of 57.8, but lower than by 6.2 the days from the prior year. And you can see charity care was at 158 for March of 2023. Just lastly, in terms of our summary of the homeless patient activity, for the 9-month period from July 2022 to March of 2023, there were 1,449 patient encounters, representing 765 homeless patients. Of the 765, 235 had multiple encounters. As you can see, the cost of homeless care includes food, clothing, pharmaceuticals, durable medical equipment, transportation, and housing, in addition to other hospital staff avoidable inpatient days. And so that total amount was $4.2 million for this period of time. So that is the report for March.
Thank you very much. We'll now move to our calendar.
Okay, I have a few things to go over. I first want to start with our Employee of the Month for April. It's Cindy Wooden, and she has been practicing nursing at Washington's Critical Care Unit for 26 years. I think many of us know Cindy. For the past 15 years, Cindy has been a staff nurse 4 in the ICU. She's originally from Canada, where she received her nursing diploma, and more recently, she earned her Bachelor of Science in Nursing. Cindy's extraordinary skills and work ethic has earned her multiple awards, including the Daisy Award in 2022 and Nurse of the Year in 2004. She takes great pride in providing excellent care to her patients and their family members. As a primary charge nurse, Cindy commits to maintaining a culture of safety and is a strong advocate for all the patients in the unit. She consistently works closely with nursing staff, physicians, supervisors, and managers in order to coordinate the highest level of patient care possible. She is a committed team leader and is always looking for ways to improve quality, safety, and the patient experience. As a staff nurse 4, Cindy is committed to continuous improvement by being involved with Shared Governance Council. She is heavily involved with the operations and coordination of the ICU Unit-Based Committee. She is an active member of Professional Engagement Council Committee and Physician-led Code Blue Committee. In addition to her nursing duties, Cindy was integral to the magnet redesignation process and guided the nurses through the complex process of preparation and achieving success. Cindy has embraced a leadership role at Washington Hospital, and her coworker says she creates an enjoyable work atmosphere where everyone feels supported. While the awards are appreciated, Cindy is quick to point out that providing care to our patients and their family is truly the rewarding part of her job. Cindy and her husband currently live in Livermore. When not working at the hospital, Cindy and her family enjoy traveling. A former marathon runner, Cindy still enjoys exercise and being outdoors. So we all want to thank Cindy for all that she does for the healthcare system. All right, and then moving on to the calendar. Just want to go over the past health promotion and community outreach events. Bring those up. And just wanted to point out we had a couple of very busy health promotion events. We had Dr. Khalsa, who talked about life after stroke. You can see they had 70 live views and over 400 people accessed it later. Also, you can see Dr. Bonner talked about robotic-assisted knee replacement, 108 live views and over 600 accessed it later. Also, just want to say if anybody does want to go back and, from the community, look at any of these past health promotions, they can do so on our YouTube channel. Moving on to the next ones, you can see that, move to the March 30th, there we go. Some of the other ones that happened during March and the beginning of April. I do want to mention that we celebrated Doctors' Day on March 30th, and again, really want to thank our physicians for all that they do for the healthcare system and for our patients every single day. They really are such an integral part of the care team and ensure that our patients get the care they need. So really want to thank all of our physicians on the medical staff. Then also just want to mention on April 4th, you can see that we did have a hybrid event in terms of for health promotion, and Dr. Seigel talked about the aging spine, and we had 94 live views and over 460 individuals accessed the talk later on. So that was a very good one and well received by our community. Moving on, you can see in terms of the upcoming health promotion and community events, the number of the ones that we have coming up, and you can access them and get information on them on our website. And so you can see that on April 15th, we're hosting the Spot Skincare Cancer Screening event at the Nakamura Clinic. Also on the 18th, Dr. Wood is going to be talking about early stage breast cancer, and that will be on Facebook Live and YouTube. You can see the other ones that are happening in other places. Moving on to the next group, you can see through the end of April and beginning of May, we have other health promotion events that we are going to be attending in our community. I do just also want to mention on April 22nd, we are working with the city and many other organizations in this community to celebrate the Go Green, the Earth Day celebration, and that is going to be happening in downtown Event Center and Plaza in Fremont. And so I just hope everybody can come by and see that. I know there's a lot of work that many community organizations put into that. And that, lastly, on May 2nd, you can see Dr. Asuko is going to be talking about carotid artery disease on Facebook Live and YouTube. Those are some of the ones that are coming up. I do want to mention a couple of awards. First of all, we were recognized from the California Department of Health Services. We received a Quality Synergy Award for outstanding performance towards clinical goals and comprehensive strategy. This is part of what we call our QUIP program that we participate in, and so we were one of 2 top performers for 2021. So really want to thank, really this is a collaborative effort that involves both the medical foundation and the healthcare system, and really focuses on children's preventive care, maternity care, and behavioral health integration. I also do just want to state that on April 8th, I know many of us attended the HERS Breast Cancer Foundation, and the healthcare system received a really important award called the HOPE Award. And part of at the event, the annual People with Purpose Pink Tie Gala, and really HERS recognized the healthcare system for all of its work in this community and what we've done in terms of breast cancer, and our partnership with UCSF Health and also with HERS. So that was a very special award that the healthcare system received. Moving on to a vaccination clinic, you can see that we've done about 99,000 vaccines. Things, as we know, have slowed down some in terms of that since the very beginning of starting that. And then lastly, in terms of the foundation, the charitable foundation report, I do just want to mention we do have our annual golf tournament that's coming up on May 4th. At Castlewood. It is almost sold out, but we also are having a bocce ball tournament. So if you don't play golf, come and play bocce ball. And then lastly, we do have on October 14th is the 37th annual Top Hat Gala. So those are a few dates for everybody's calendar.
Thank you very much, Kimberly.
All right, thank you.
We are now ready to move on to some very important action items. We're going to consider 3 issues concerning the employment agreement of our CEO, Kimberly Hartz. This consideration will involve the fiscal year ending in June 30th, 2022. And so we have 3 main issues to consider. First will be whether to adjust her base salary. The second will be to consider whether to give an incentive award for that fiscal year. And finally, to consider extending the term of the employment agreement. This is something we do annually, a very, very important part of our stewardship with our CEO. I think it would be very helpful if first we hear from the hospital attorney, Paul Kozachenko, to give us some history and some basic ideas about where we're at with this issue.
Thank you, Dr. Stewart. I'll go over a brief background so that we all are on the same page, and then talk about the history so far with Kimberly's employment and the tasks before you tonight. The Chief Executive Officer is the only employee of the district who is hired directly by the board. According to the CEO's employment agreement, the board reviews the CEO's performance annually on or before October of each year. Following the performance review, the board considers base salary adjustments and an award of incentive compensation up to 25% of base salary. Due to various reasons and with the concurrence of the CEO, the consideration of the base salary adjustment and incentive award was delayed until now. The district has a long-standing philosophy of wage parity for all employees, which includes the CEO. Wage parity means that the CEO is not paid at the top, nor is she compensated towards the bottom of the scale. The district's compensation philosophy of marketplace parity establishes a base salary for the CEO at around the 65th percentile of her peer group, and a total cash compensation for the CEO in the range of the 75th percentile of her peer group, with a maximum possible incentive award of 25% of base salary. Benchmarking executive compensation based on peer group data is standard practice for establishing reasonable compensation for executives working for nonprofits. The district's compensation philosophy reflects the district's long-standing philosophy of wage parity for all employees. As in the past, Arthur J. Gallagher and Company was engaged to provide a report, we call it the Gallagher Report, for the board's use in deciding compensation adjustments for the CEO. Gallagher is a leading healthcare compensation consultant in the United States. Hundreds of healthcare systems use Gallagher services to satisfy Internal Revenue Service regulations for determining the range of reasonable compensation. The Gallagher Report assesses the competitiveness of the cash compensation for the Chief Executive Officer. Appendix A of the Gallagher Report, which includes a list of similarly situated California organizations in the Gallagher proprietary database. The Gallagher Report is included in the board's packet. The Gallagher Report provides the board with appropriate comparability data in accordance with IRS regulations. In its report, the Gallagher reviewed the background data on the district for 2021 to 2022 and 2022 to 2023 fiscal years. Gallagher then compiled data on the compensation levels for the healthcare systems, regressed for size using data from the Gallagher's proprietary database and its salary surveys. Based on the foregoing, Gallagher prepared market charts summarizing compensation survey data at the 25th, the 50th, and the 65th percentile for the California peer group. The charts are prepared for both base salary and total compensation. Prior board action. The board approved the employment agreement for Ms. Hartz at the board meeting on June 12, 2019. At that time, the board set Ms. Hartz's base salary at 80% of the 65th percentile. In recognition that while Ms. Hartz had substantial experience and knowledge given her years of service as a senior associate administrator, she had not yet served as a CEO. The board set her base salary at 80% of the 65th percentile, or $712,000. On December 8, 2021, the board increased the CEO's base salary to $861,000, which was equal to the 50th percentile of the peer group. At the time, the board noted that it was incrementally adjusting the CEO's compensation toward the 65th percentile as she gained experience and as warranted by her performance. The board also decided to award Ms. Hartz $100,000 as an incentive award based on her exemplary performance. The board indicated that Mrs. Hart's performance justified an award of 25% of her base salary. However, due to the impact of the COVID-19 pandemic on the district's finances, the board awarded $100,000 rather than the full 25% of base salary. As to the base salary adjustment, the chart on page 9 of the Gallagher Report shows that Mrs. Hart's current salary of $161,000 is compared to the peer group, the 20th, the 50th, and the 65th percentiles. Her current salary is 6% below the 50th percentile of $918,000 and 14% below the 65th percentile of $1,006,000. As the Gallagher Report notes, as Ms. Hartz acquires experience and based on her performance, it would be expected that her base salary would be adjusted to bring her base salary closer to the 65th percentile. Mrs. Hart's current employment, as to the incentive compensation part of the discussion, Mrs. Hart's current employment agreement states that she is eligible to earn an incentive award of up to 25% of her base salary. Page 14 of the Gallagher report shows that if the board chooses to award the full 25% of base salary, the CEO's total cash compensation for the fiscal year ending 2022 would be 2% below the 50th percentile and 13% below the 65th percentile. Historically, the board has considered a number of factors in determining the amount of the incentive award portion of the CEO's compensation. These factors include consideration of the various accomplishments during the past fiscal year. The board has received a separate report from the CEO, which includes a list of accomplishments for the board's consideration in determining an incentive award. Based on Mrs. Hart's current base salary, the board can decide to award compensation of between 0 and 25% of base salary, which would be $215,250. Lastly, the board considers an extension of the CEO's contract. In addition to reviewing the cash compensation, the board typically agrees to extend the CEO's term of employment agreement to maintain a 4-year term. So the possible board actions tonight are, in summary, are a base salary adjustment based on performance and existing compensation philosophy, an incentive award of up to 25% of base salary, and an extension of the term of the employment agreement. And that's the background.
Thank you very much, Paul. I think that's very, very helpful. The report's been very comprehensive. I appreciate that.
You're welcome.
I think it's important to just emphasize a couple of items that Paul has presented there. One is that we've long had a policy of having our CEO basic salary based on the 65th percentile of, and you know, that can be confusing at first when someone outside this room may hear that. And what that means is we look very carefully at this Gallagher report, which is a report of many hospitals very similar to this hospital, and the base salary and the consideration for the CEO in all of those various hospitals. And so our philosophy has been to along with our basic policy of parity with salaries throughout the system, our philosophy has been to base the CEO salary on the 65th percentile of what all of those figures have been. Because we hired Kimberly in 2019 as a brand new CEO. He'd worked many years at the hospital, but had never worked as the CEO. It was appropriate to start her at a lower rate than that 65th percentile, and to gradually, over a period of years, raise that to our goal and our philosophy to the 65th percentile. At the end of the last fiscal year, Kimberly had completed her 3rd year as the CEO. I think it's important, Paul mentioned it, but again, I want to mention it again. We're somewhat late in considering this salary adjustment, simply because of all the things that have gone on in the last couple of years, and COVID and whatever. There have been many, many difficulties. So we are considering the fiscal year ending June 2022. And at that point in time, she had completed her 3rd year as CEO. And our basic philosophy has been to gradually raise that salary based on performance, of course, so that in 4 or 5 years we would be at that 65th percentile. Now, speaking of the year ending June 2022, I do not think there's any doubt that Kimberly's performance was outstanding. looking at the information of the current Gallagher report, just to keep Kimberly at the 50th percentile, we would need to adjust her salary significantly, $918,000 per year. But if we want to keep with our plan, we need to move a more substantial adjustment if we believe that Kimberly has met those expectations. So, as I just indicated, Kimberly's performance during that period of time was outstanding. The EBITDA generated was well above budget, and she did this while the COVID pandemic was still with us. So, to jumpstart the discussion here this evening, I have a proposal to make that we can discuss and work through. I'd propose that we consider adjusting the base salary to close to the 65th percentile, somewhere by perhaps 95%. In other words, that would be consistent with our plan to gradually move that towards the 65th percentile based on performance. Based on the performance for that year, I think it's appropriate that we move her salary closer to the 65th percentile. And I'm proposing that we do that to 95% of that percentile. I hope I'm speaking clearly enough. Sometimes that can be confusing. So that number, 95% of the 65th percentile, that number would be $955,700 per year. I think that number is in keeping with our prior promise when we first hired Kimberly, and I hope it sends a message that we truly value her leadership and her efforts. Now I'd like to hear from my fellow board members on that issue, and we can discuss that completely. I'm anxious to hear from all the board members on that.
Well, I'm prepared to make a motion, Mr. President. If you want to hear some of the other board members.
You're ready to make a motion.
Well, yeah, I'm looking for action.
Well, I'm just looking to see if we're all generally in agreement with what we're talking about.
I think I, like you, have reviewed the Gallagher data, looking at the California peer group, and with a thorough understanding of the board philosophy of incrementally increasing the salary over a period of time to approach that goal of the 65th percentile. And looking at Kimberly's stellar performance over her period as in her tenure as CEO, and the growth that she's shown during that tenure, I'm in complete agreement with your proposal.
Thank you. I think it's very important at this time.
Blue, pavilion second floor, critical care pod D, room 235. Blues, pavilion second floor, critical care pod D, room 235. Blue, pavilion second floor, critical care pod D, room 235.
Business continues at the hospital. Yeah. I think it's important, again, to emphasize the Gallagher report at this point. The Gallagher report is a report on the salaries of many, many hospitals that are very similar to this hospital. And they give us a report showing the general salary of the CEOs in those hospitals. And we've always felt like we need to be competitive with the hospitals around us, and we have set this goal of having it to be at the 65th percentile. So that makes for, I think, an important basic understanding of where we're at, that we're working with parity with other CEOs in a significant number of hospitals. So Dr. Nicholson's anxious to make a motion.
Would you like me to proceed, or?
And unless, if there are other comments that we need to hear from.
No, I mean, we have always followed this Gallagher's report, which is one of the leading compensation consultants in the country. So, and they have always provided us a cohort of hospitals which are similar. And like the President mentioned, we have always followed the 65 or 65th percentile. And although Kimberly has been as a CEO for 3 years, she is still about 14% less than the 65th percentile. So I think, I have no hesitation in making this move and bringing it at least close to the 65th percentile.
Thank you, Dr. Ethan. Okay, Bill, I believe we're ready for your...
Okay, yeah.
Dr. Stewart, can I ask you to,
I'm sorry.
to open the public hearing in case there is anybody on the line that would like to speak to this issue before you move and vote?
I apologize.
No, it's okay.
I have that written in red here in my notes. Somehow or another, I get all anxious
Yes.
to do that. It is very, very important. I apologize that I haven't done that. It is very important to open this meeting to a public hearing even, and to allow for any of the public to speak on this issue at this point in time. So I would invite anyone listening on this meeting with Zoom or otherwise to comment regarding this consideration that we're making here tonight. So are there any comments from the public? There appear to be none. And so at this point, I would close the public comment on this issue. Are there any board member who wants to make any additional comments? Thank you. Now we're ready for your motion.
Okay, Mr. President, I hereby move that the board increase the chief executive officer's base salary to $955,700, which is near, actually 95% of the 65th percentile of the California peer group, and that this adjustment shall be effective as of July 1, 2022.
Second?
Thank you. Do we have a second?
Second.
I'm sorry, I didn't hear you.
And the mask.
We have a second from Dr. Reed. We take the roll.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Eapen,
Aye.
Director Yee,
Aye.
Director Wallace.
Thank you. That motion passes. Congratulations.
Thank you very much.
You have earned that many full.
Thank you.
Many full.
3 years that were unprecedented.
Well, I do just want to say that, as you know, it takes a team. And it takes the VP team, it takes the executive staff team, it takes the management team, and everybody else. And so we have a really strong team at Washington, and that is why the success that we've been able to achieve is because of the team.
And your leadership. You are very collaborative. And you encourage people to be their best. And they want to step up and be the best because of your style of leadership. It's very effective. I hear it on the floor, how much they appreciate you. And I think that just your leadership just trickles down through your senior staff and your managers, and it's very effective. In a good way.
Thank you. Thank you.
Our second issue to consider in regards to CEO is the award of incentive compensation. As Paul has mentioned tonight, her employment agreement allows for a 25% incentive compensation, 25% of her base salary, which would be $215,000. In my view, Kimberly deserves an award of the full 25%. However, she has expressed some concern about that amount, given the anticipated challenges facing the district in the coming year. In December of 2021, we awarded a $100,000 incentive compensation award. That was less than she deserved at that time. We wanted to be prudent coming out of the COVID pandemic. I want to be mindful of her concerns. She is a great leader, and all of these issues revolve around her leadership and the progress and the future of this hospital. So I think it's very prudent to consider her wishes and her concerns. There are certainly many headwinds facing our hospital at this point in time. We've seen that tonight in our physical report, in our financial reports. Nevertheless, I think it's important that we recognize Kimberly's performance. I think she well deserves an award of an incentive compensation. I think we should award something. I think we should award more than we did last time. So at this point, I propose that we consider an award of $120,000. This is still far less than she deserves. But in keeping with the challenges we are facing, before I ask the board's comments, I want to just note the following, some of the key accomplishments of that year. They were significant. Her performance during that fiscal year ending June 22 was outstanding. Everyone can read the annual report, but I want to note that our EBITDA variance from the budget was $28,000.
28
million. I'm sorry. I'll read that. $28 million. I don't often deal with billions of dollars in my private life. I apologize for that error. The funds generated from that positive budget variance will fund needed capital improvements, including state-of-the-art medical technology. This institution is a non-profit institution. All of the capital raised in this institution goes back into the institution. I also want to note that she led the successful efforts to designate Washington Hospital as the next adult trauma center in Alameda County. This is a tremendous accomplishment. Up until now, a person in this area that experiences a traumatic event like a car accident or something that requires immediate care, they need to be transported to the nearest trauma center, which is Castro Valley. And in this last year, our hospital has been designated the next trauma center for Alameda County. This is a tremendous accomplishment for the hospital, but even more valuable for each individual person in this community. And we're very proud of that accomplishment. The other thing I'd like to mention is our affiliation with UCSF. UCSF is a medical center that is one of the best and most important medical centers in the entire world. And through Kimberly's work, we have developed a very close relationship with CSF. This year, Kimberly's leadership, we created the Washington UCSF Cancer Services Joint Venture. That means that someone here in this community will have access to the tremendous capabilities of that UCSF Cancer Center. Our community is aging, and cancer will become more and more of a difficult issue in this area. And the fact that we will have in this community, in this very hospital, UCSF services in cancer will be a tremendous value to all of us. I think that's a tremendous accomplishment. I'd like now to ask if considering this award of incentive compensation, I just would invite board members to make any comments that they would like. Pretty quiet again.
Well, I'm always happy to speak, Mr. President, because I have a lot of feelings and thoughts on this. And I think I would share the board's thoughts that Kimberly is entirely deserving of the full incentive compensation. You messed up a little bit on the 28,000 versus 28 million number. I know the board would have been very happy to have a $28,000 positive variance, and we were just absolutely delighted when we had the 28 million positive variance on our EBITDA, which actually is money that we can use for services that we provide to our community. So that's a huge benefit. You brought up two very important points. One is the trauma center, and the other is the UCSF affiliation. Either one alone would be deserving of the full incentive compensation, because these are two things which will have a tremendous long-term impact on the care that we deliver at this institution and how that benefit accrues to the residents of the district. So these are very powerful things. And time will show how important this is. So when we look back 10 years, 15 years, 20 years, if we should be so lucky to be alive at that time, we'll be able to see how important these things were. I share your sentiment that Kimberly is entirely deserving of the full incentive compensation award. But in the medical field, we deal with realities, and realities are here, and there are challenges afoot, and we have to deal with those as well. So I understand Kimberly's reticence about a full incentive compensation award, and I would target an award which is higher than the last one we gave, because clearly the performance is there, and I would target an award around $120,000. And I can put that into a motion at whenever you should ask me to, Mr. President.
Any other comments from any other board members?
I mean, incentives, I believe, is always given when performance is above the expected. And I think Kimberly has definitely proven that. And all the accolades have already been mentioned what the hospitals attained during a term. I have absolutely no hesitation in giving the incentives.
Thank you.
I think that was a thumbs up, Jeannie.
Yes, go for it. I don't want to. I don't need to add anything.
I will now open the meeting to a public hearing on the subject of an incentive award. Does anyone from the public want to speak? I ask you to speak now. There appear to be none wishing to speak at this time. So at this point, I would close the public comments on the issue and ask the board if there are any more comments that they would like to make. If there are none, I will entertain a motion from Dr. Nichols.
Mr. President, I move that the board award incentive compensation to the CEO based on the CEO's outstanding performance in the amount of $120,000.
I second that.
We have a motion and a second. Take the roll, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Eapen,
Aye.
Director Wallace.
Thank you, Cheryl. That motion passes. Glad that does, Kimberly.
Thank you
We're
very much.
very,
Very
very grateful
generous.
for what
Thank
you
you.
do.
Thank you for all your hard work. I know you don't do it for the money. You do it for the community. And whatever the amount would have been, wouldn't have changed how hard you work. Appreciate that. Appreciate your heart. Thank
And
you.
I would second that comment. Director Yee, Jeannie, is here at the hospital many, many days more than me. Bill is here more than me. But whenever I'm here, Kimberly's here. And the hours I would hate to estimate. We have one other issue that needs to be considered. That is the extension of the term of employment for Kimberly. This final issue is for us to consider whether to extend the term of Ms. Hart's contract, which we typically do when we consider the CEO compensation. I would like to see a motion that would extend the term for the new effective term from July 2022 to June 2026. I think that extension is well-deserved. I think it's obvious from all our discussion here tonight that we want to do all that we can to maintain the employment of the CEO. Very, very effective CEO, and the least we can do to extend that employment agreement to June 2026. Are there any comments from board members on that?
Enough said. I agree.
I'm gonna handcuff you here. You're not going anywhere.
Again, I would ask for public opinion on this, opening a public hearing and asking if there are any members of the public that are anxious to speak about this. We are open to hearing from you. We are anxious to hear from anyone who would like to comment on this issue. Again, hearing none, I would now close the public hearing and ask if anything more from the board at all. And Dr. Nicholson will entertain a motion on the subject.
Thank you, Mr. President. I hereby move that the employment agreement be extended for 2 years for a new term beginning July 1, 2022, and ending June 30th, 2026, and the President of the Board be authorized to execute an amendment to the employment agreement consistent with the actions taken here tonight.
Thank you.
Second?
A motion and a second on the issue. Cheryl, if you could take the roll on that.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace, Director Yee,
Aye.
Director Eapen.
Aye.
Wonderful. That's,
Mr. President, I just wanted to make a comment that it's unfortunate that Mr. Wallace is not here tonight, because I know he would concur in the actions that we have taken here. This is one point where I might feel a little bit comfortable speaking for him, but I'm sure he would agree.
I agree.
I appreciate your comments. And I think it's important for the public to know that Mr. Wallace has been closely involved in whatever we've talked about on this issue. And he has been very, very supportive. So we appreciate that reminder. It's nice to do that. Okay. There being no further business this evening, I declare this meeting adjourned. Thank you all for your attendance. Thank you all for being here.